So Dr. Naban at ASH this year presented on a retrospective review of about 200 patients who have peripheral T-cell lymphoma across a number of subtypes. The purpose of this was to look at a real-world experience with peripheral T-cell lymphomas in the United States. He had shown that the median survival for these patients, again, is about 6 months, although there's a subset of patients who certainly had much longer remissions. And when you look at his curves, it looks like there's a percentage of people who may have been cured with their second or third line of therapy. It was clear from the work that he presented that upfront autologous transplant for consolidation was not as commonly practiced in the community as it may be at certain large academic centers. But it's hard to draw conclusions as the patient populations may be notably different. Yeah, I think there's still a lot of questions left to answer in peripheral T-cell lymphomas. I think specifically in the relapsed refractory setting, there's a number of either combinations of therapies that are currently being used or novel therapies that are being explored. So for example, we had published previously on the combination of romidepsin and lenalidomide and romidepsin, lenalidomide, and carfilzomib in 2 independent studies in peripheral T-cell lymphoma, which look like they have overall response rates in the 40 to 50% range. The response rates are higher, near 100% in angioimmunoblastic T-cell lymphoma from these combinations. And so there's a clear push in the T-cell lymphoma community of experts to start to identify which histologies benefit from certain types of drugs, and maybe angioimmunoblastic T-cell lymphoma it should be treated differently than other types of peripheral T-cell lymphoma, especially in the relapse setting. Similarly, Owen O'Connor's group at this meeting is presenting on romidepsin 5-azacitidine, which also looks very promising in angioimmunoblastic T-cell lymphoma. There are efforts through the U.S. intergroup to consider comparing these therapeutic strategies head to head, but that is being explored. Additionally, there's a role for PI3 kinase inhibition in peripheral T-cell lymphomas as well. Dr. Horowitz and colleagues presented on duvelisib in combination with romidepsin or duvelisib in combination with bortezomib at this meeting as well, with response rates of 50 to 60%, and some of those responses being quite durable, which in fact, some were so deep that they led patients to move on to an allogeneic transplant. And so that's also a promising strategy. Duvelisib is being explored in a national phase 2 study in peripheral T-cell lymphomas to better identify the efficacy in these rare diseases. So I think there's a number of potential new strategies that are being explored by ourselves and many of my colleagues to try to improve the care for people with peripheral T-cell lymphomas overall, and to try to develop therapies that are tolerable also long-term for those who cannot get an allogeneic stem cell transplant. And we're also investigating the role of transplant itself further in peripheral T-cell lymphomas and to identify who best benefits from this. I think the other challenge that we face is that the histology is not as well understood, and the pathophysiology is not always as well understood in peripheral T-cell lymphomas. And so we're learning that a group of people who have PTCL NOS may in fact really have, by gene expression profiling or by genomic sequencing, may really look more like AITL or a different disease. And as we have better understanding of the biology of these diseases, we'll be better equipped to develop new therapies for them. As a junior investigator who is devoted to improving the care of peripheral T-cell lymphoma, it's a very exciting time. I think the results of Echelon 2 are the first study in peripheral T-cell lymphoma to show a survival benefit, which is incredibly exciting for our community. And then we're very hopeful as we've developed new therapies and have better understanding of the biology of these diseases that we'll be able to move the bar forward both for patients in the upfront setting and hopefully also in the relapsed refractory setting.